Hello, and welcome to another installment of the Olea educational webinar series. My name is Adam Davis, and I am the Chief Medical Officer for Olea Medical. Today is the second of our two-part series discussing the future of MRI. Last week, we discussed general trends and new innovations in hardware and software technology, as well as new sequences and applications of MRI. Today's lectures are organ-specific. I'm very excited that we will be discussing the current and the future state of MRI imaging for the most prominent organ studied today by volume in MRI, imaging of the breast, the liver, the prostate, and the brain. We will also have a cautionary lecture on the standards of conducting and reporting medical studies in general medicine, as well as imaging studies in particular. I'm very excited to hear today's presentations. Our speakers, Drs. Taouli, Bittencourt, Nael, and Kressel, are well-recognized experts in their respective areas of interest, and I want to thank each of them for their time. Making the time to be with us today. The format for today's lecture will be first the presentation of 5 15-minute presentations, and then a live interactive roundtable with all of our speakers present. Our audience is encouraged to ask questions via the Q&A tab located at the bottom of your screen during the initial part of the session, and we will try to answer as many of these questions as possible during the concluding discussion period. So without any further ado, let's move on to the presentations themselves. When the presentations start, if I can ask all of the presenters to turn off their video and their microphone. Dr. Pinker, please stay on. The first speaker in today's webinar is Dr. Katja Pinker. She is a professor of radiology at the Weill Medical College of Cornell University in New York. She is an attending radiologist at Memorial Hospital for Cancer, and she practices at the Memorial Sloan Kettering Cancer Center. She is the head of translational imaging research and the head of breast MRI imaging at Memorial Sloan Kettering. Dr. Pinker is affiliated with the Department of Scientific Computing at Florida State University. She is a globally recognized expert in clinical and translational oncologic breast imaging. A particular area of interest includes metabolic and high field imaging, as well as biomarkers and hybrid techniques such as MRI PET, and as well as the application of artificial intelligence in oncologic imaging for precision medicine. She has authored over 180 peer-reviewed articles. Today, Dr. Pinker will be speaking to us on artificial intelligence applications in magnetic resonance imaging of the breast. Thank you, Dr. Pinker.
Today, I want to talk about AI applications in breast MRI. And when we think about it, so we have moved to the era of precision medicine. So we have moved away from the one-size-fits-all approach, which was designed for treatments of the average patient. And we know patients are not average. Every patient is different. And this precision medicine approach provides treatment and prevention for the patient that takes into account individual variabilities, like in genes, environment, and even lifestyle of the person. So an integral to such a precision medicine approach is systems biology. The systems biology is the study of complex biological systems, their interactions and their changes over time and with environment. It crosses over all disciplines like biology, engineering, bioinformatics, and also, of course, imaging. It uses computational mathematical modeling to integrate the information that we get from all of these different disciplines. And this is like where AI can play, the rise of AI can really help us. So artificial intelligence in medicine has been facilitated with the development of sophisticated medical imaging techniques, new approaches to data analysis, and the development of high throughput methods to extract and correlate these multiple parameters we are getting from imaging. So this is a sort of I do not really think it's a newish direction in medical research. AI-enhanced medicine. So where are we at the moment? We are definitely no longer at the Stone Age, but are we already fully bionic yet? I don't think so. I think we're currently in the stage where we are finding meaningful clinical implementations for AI-enhanced medicine. And today I will talk about the use cases of AI-enhanced medicine in breast MRI that we currently have. So we have, of course, detection, but the majority of work is on lesion classification. And then when we have a breast cancer, we take it a step beyond. It is characterization, prognosis, and prediction. And in cases where patients do not have a cancer, we can provide a risk assessment with AI-enhanced MRI. So the first studies all focused on lesion classification, and this is one of the early studies which actually merged the information for multiparametric MRI with the aid of artificial intelligence. They looked at the parameters we can get from DC MRI, T2-weighted and diffusion-weighted imaging, and compared lesion classification that was aided by AI with radiologist review, which is the gold standard in this setting. And it was shown that when operating at the same sensitivity level as the radiologist, with AI enhancement, we have less false positives, so an improved lesion classification. And it shows that we can add something by implementing AI. Another study which looked at a particular subset, lesions that were already on standard of care MRI by subjective radiologist review were recommended for biopsy. Radiomics and machine learning was applied to those cases, both for DWI, DC MRI, and in a multiparametric framework. And it showed that it allowed an improved evaluation of those suspicious enhancing tumors that were recommended for biopsy without missing cancer. So we can facilitate a more accurate breast cancer diagnosis while at the same time, and this is, I think, the goal we're looking for, obviating unnecessary breast biopsies. In this study, the authors looked at a particular subset of patients, those who will undergo a lot of biopsies in their lifetime, high-risk screeners, patients with a BRCA mutation that undergo high-risk screening with MRI. And in those patients, our level of suspicion is immediately higher when we see a small, tiny enhancing lesion, probably with even benign features. These are hard to characterize with BI-RADS assessment, qualitative assessment. We also know that in the setting T2 and is not that helpful and diffusion limited because of spatial resolution restraints we currently have. And in this study, we compared radiomics and machine learning for assessment of those lesions with radiologist review, and it was shown that it significantly improved the diagnostic accuracy, 79.3% as compared to 53.4% with BI-RADS alone. So we can potentially spare those patients unnecessary biopsies over the lifetime, rather recommend those lesions for a follow-up, which we put and obviate a biopsy. When we go beyond classification, we have molecular subtyping with MRI. Why is that relevant? Well, treatment decisions are nowadays based on molecular subtypes. These molecular subtypes are typically derived from genetic testing, or from either formal genetic testing or by receptor surrogates from a biopsy sample. The thing is, the biopsy samples come from one area of the tumor and are inherently subject to selection bias. So the idea is that with imaging, where we assess the tumor as a whole, we potentially can provide a more accurate subtyping. So to put it plainly, you biopsy a lesion and you miss the part where it's hormone receptor positive. So you could offer the patient something, but you miss it. And the idea is with molecular subtyping DC MRI, and this is a standard of care MRI the patient is getting in her course of her staging anyway, we can provide more information. And it was shown that there are specific radiomic signatures associated with contrast-enhanced MRI for receptor status and molecular subtypes, and we could get that with good diagnostic accuracy. And the idea is like we can get prognostic indicators from the entire tumor, and we potentially might also monitor biology changes during treatment. There's not only neoadjuvant chemotherapy, but there's also now new endocrine treatment, which patients get for a longer period of time, like sometimes even a year, until they eventually go for surgery. The same concept can be extrapolated to DWI, and the idea, why is this attractive? Why not stick just with contrast-enhanced MRI? First of all, you have to give a contrast, and second of all, when we are thinking about monitoring changes or a response assessment during treatment before surgery, we potentially want a non-contrast method with a short scan where we can get similar information. And it was shown that when we use that, apply radiomics and machine learning to diffusion-weighted imaging using the ADC map, actually also specific subtypes like luminal B and HER2 carry distinct radiomic features, and we can tweak that out from a contrast-free scan. When you put this information together, it stands to reason that this will be equally sensitive or even better. It was shown that when we use machine learning with multiparametric MRI, that we can also aid in the non-invasive differentiation of triple-negative cancers from luminal A's. And triple-negative are the ones where we do not have any other treatment options. These probably need intensified treatment, whereas the luminal A breast cancers, we can de-escalate and have actually targeted treatment available. One really exciting application of AI-enhanced MRI is going further into the actual tumor gene expressions and correlation with imaging phenotypes. And in this study here, they showed that there were associations between enhancement and sharpness of the tumor margin with the ribosome. So MRI features may be used as imaging biomarkers for drugs that target the ribosome. So we are going even further into targeted treatment. A similar concept was applied in this study, looking whether we, from a standard of care MRI, this is the MRI the patient will be getting anyway during the course of the treatment, we can see how is PD-L1 tumor overexpression. Why is that relevant? PD-L1 tumor overexpression is associated with worse survival and treatment response, whereas PD-L1 TIL overexpression is associated with improved patient outcomes. And in this study, with this initial feasibility study, radiomics analysis with machine learning was able to predict PD-L1 mutation status with an accuracy of 88.2%, whereas standard of care assessment with BI-RADS was not useful. So with DCMRI, with AI enhancement, we can derive prognostic and predictive information, and in the future potentially select our patient for targeted treatment. And you have to think about it. So far, we have to do a formal genetic assessment for that, which is costly and to some patients just not available. So other factors where we can AI enhance our performance is in treatment response prediction. So in this study here, they looked at HER2 overexpression from levels from standard of care MRI coupled with AI, and also prediction of PCR. And it was shown that a machine learning model that was able to predict, a machine learning model that included clinical and radiomic features worked best, and it could predict HER2 heterogeneity with a diagnostic accuracy of 97.4%. And predict PCR with an accuracy of 83.9%. So this is another exciting tool where we can actually aid in treatment guidance. Also, this is not a one-off study. There are other studies like this one here who took it beyond and also looked at other sequences, DCE and DWI, and combined that in a multiparametric model. And they showed that prediction of response to neoadjuvant chemotherapy with Herceptin was possible with an AUC of 0.97. In this study here, which actually looked at virus descriptors and the analysis of those with machine learning, could actually show that not only can we predict response with a good diagnostic accuracy, but we can also predict survival outcomes in the sense of recurrence-free and disease-specific survival with high accuracies of 87 and 92%. So we can, as imagers, definitely with AI enhancement, provide additional information to guide patients' treatment selection and monitoring. If you're interested in this aspect of treatment response assessment, this is an overview article which basically provides a very good overview, which also shows that while initial studies employed machine learning due to limitations in data sets, the field is moving towards deep learning techniques, which seems to be more powerful and robust. Another area which I think is very exciting is predicting recurrence scores. In this study from 2019, their conventional MRI was used to predict oncotype DX recurrence scores, which predicts whether the patient has a high or low risk of recurrence and can benefit from adjuvant chemotherapy, which of course is associated with the cytotoxic effects that can have. In this study, they actually looked at 3-class prediction with the results of the Taylor X study. We know now that actually low and high risk prediction prediction is what we're doing in clinical practice. And when we look at the 2-class prediction and even the 3-class prediction, the MRI had an AUC of 0.92%. So we can actually, from a standard of care imaging test, we can actually predict recurrence scores. So in a setting, again, where a patient doesn't have access to formal genetic testing, this could be a valid alternative. This is a study who looked at another multi-gene classifier than Oncotype and actually found similar results. So there is information that can provide those results from contrast-enhanced MRI. So I think this actually would be a very exciting, meaningful implementation that I think should make it in the clinics more faster than anything. Another very exciting area is risk assessment. In this study, they looked at predictions of patients without a cancer, but at potentially a higher risk of cancer. And in this study, they looked at MRI images to predict 5-year breast cancer risk and compared it to the gold standard, the Tyra-Cuzick, what is currently used in practice. And the deep learning model from an MRI achieved an AUC of 0.63. You might say, well, this is not that grand. But the Tyra-Cuzick standard of care in clinics, what we're currently doing, had an AUC of 0.49. So the deep learning model improves our individual risk discrimination. And I mean, this is something we should actually also move forward in the clinics as fast as possible. So when we want to summarize, the field of AI-enhanced breast imaging is rapidly evolving with numerous applications. It's an unprecedented opportunity for us as imagers to contribute even more to our patient care and reshape the way we care for our patients. A word of caution, the road to this vision is still long, and there are other factors that we have to consider apart from our actual data we're acquiring. There are regulatory, ethical, technical issues that have to be considered. The standard, the obvious ones are we need continuous study, we need standardization, we need larger sample sizes and subgroup analysis to define meaningful clinical implications. But what I also want to mention is that there are other challenges. There's the over-enthusiasm. At the beginning, everybody is excited what we can do, but it may create false, unrealistic expectations and a false sense of capabilities of AI, with then on the long run, disappointment and hesitancy setting in. The opposite is fear that which may result in over-restricted guardrails that impede the implementation of AI and the fear of the radiologist to be replaced. I think there's so much work to do. We will not be replaced, and also consider that a computer is not a legal entity. It will be always you signing off the report. But this may change, but at the moment it is like that. And one thing which is I think a very crucial part, managing change is always difficult. It has to involve all stakeholders, not just radiologists, clinicians, but also insurance companies, patients. So it's multi-layered on different levels, and that will be also a thing to tackle. But where are we now? Are we at the infancy of AI-enhanced medicine and breast imaging? Well, I think we're not at the neonatal stage. Where are we? I mean, in reality, all my friends
They grow up so fast.
And I think that will hold true for AI as well. I think there will be rapid developments, and the road to this vision is long, but I think we will move along this road very fast. Thank you very much.
Dr. Pinker, thank you. I very much enjoyed that lecture. I must tell you that I fall into the category of overenthusiastic about artificial intelligence, and I will be sure to ask you many questions during the roundtable about that. Thank you very much. Our next speaker, Dr. Bachir Taouli, is a professor of radiology at the Icahn School of Medicine, and he practices at Mount Sinai Medical Center in New York City. He is the vice chair for translational research in the Department of Radiology and is the director of cancer imaging at Mount Sinai Hospital. He completed medical school and radiology residency training in Paris before moving to the University of California, San Francisco for fellowship training. And I am happy to say he then joined the staff at my former hospital, New York University Medical Center, before he moved on to Mount Sinai in 2009. He is a globally recognized expert in liver disease and abdominal oncology. He has held multiple National Institute of Health research grants, is the author of more than 165 peer-reviewed articles, as well as multiple book chapters, and has lectured nationally and internationally on the subject of liver disease, particularly oncology. He sits on numerous high-profile radiology society program committees, former associate editor of AJR. It's a pleasure to have him here today. Today, Dr. Taouli will be speaking to us on abbreviated MR imaging of the liver. Thank you.
Hello, my name is Bachir Taouli. I'm from the Icahn School of Medicine at Mount Sinai in New York, USA. It's my pleasure to participate in this Olea-sponsored academic webinar 2022 titled Future of MRI. I would like to discuss abbreviated MRI of the liver. My disclosure is listed here. In terms of discussion topics, I'd love to cover the rationale of abbreviated MRI or AMRI, discuss some options can be used for performing abbreviated MRI, and I will review main applications which pertain to liver cancer screening and surveillance, assessment of liver metastases and diffuse liver disease, and I will briefly discuss pitfalls, limitations, and future directions. So let's discuss the AMRI rationale. With abbreviated MRI, you are trying to get the same amount of clinical information as a full or standard MRI using the minimum number of sequences for a targeted clinical question, for example, liver cancer screening. Abbreviated MRI is different from fast MRI, which I will not discuss here. Abbreviated MRI can be used without or with IV contrast and typically has less images or less sequences. Thus, there's a significant reduction in the acquisition time. Indirectly, this may improve workflow efficiency and patient throughput because of the decreased acquisition time. The value of this may be increased by reducing costs and improving quality or service, and as shown here in this equation, and this could be really a more cost-effective solution for certain clinical indications. In terms of liver abbreviated MRI options, there are multiple options described. The easiest is going to be a non-contrast abbreviated MRI, where you combine typically a T2 and diffusion, sometimes a T1 weighted image. Sometimes also you can do PDFF and MR elastography for diffuse liver disease. Here you do not inject any gadolinium contrast agent. It makes it really the easiest protocol compared to contrast-enhanced protocols. There has been also description of using abbreviated MRI with a liver-specific agent such as gadoxetate. It's called hepatobiliary phase or HPP AMRI. This is where you can inject the patient outside the room, wait about 20 minutes, and acquire a combination of T1 at the hepatobiliary phase, T2 with or without DWI. No dynamic imaging is performed. The third option for liver AMRI is to do a dynamic abbreviated MRI with an extracellular gadolinium contrast agent, where here you're combining dynamic pre- and post-contrast T1 with T2, where MRI is used almost like a CT, and the contrast is injected with a power injector on the MRI table. So I would like to discuss briefly gadoxetate enhanced MRI in HCC applications. Gadoxetate is a liver-specific agent with high accuracy for HCC detection in cirrhotic liver, especially for lesions between 1 and 2 cm. It does impact the diagnosis of MRI, but also for the diagnosis of early HCC and high-grade dysplastic nodules. It has been shown in a prospective Korean study comparing the performance of gadoxetate MRI, full gadoxetate MRI, to ultrasound, that it was much more powerful for HCC screening compared to ultrasound. In liver metastases also, gadoxetate has a role by delineating the lesions better, thus increasing the conspicuity of the lesions, which are typically hypointense on a delayed hepatobiliary phase, although there has been description of colorectal cancer mets with residual uptake, likely due to the presence of fibrous tissue. In a meta-analysis published in 2012, there's pooled weighted sensitivity of 0.93 and specificity of 0.95 for detection of metastases, showing excellent performance. There's also potential of cost savings using ganoxetate, as shown in a trial performed in Germany in 2016. So let's discuss specifically abbreviated MRI for HCC screening and surveillance. So liver cancer is rising. About 6% of global cancer incidence is due to primary liver cancer. It's the fourth cause of cancer death worldwide. And over 50% of cases worldwide come from China. In the US, it is one of the fastest growing cause of cancer over the last 2 or 3 decades. Incidence multiplied by 3. And there will be approximately 41,000 adults diagnosed with primary liver cancer. This includes HCC, cholangiocarcinoma, and mixed tumors with high number of deaths. It's known that men are more likely to be diagnosed with the disease compared to women, and these numbers may likely increase due to the increase in obesity. The current guidelines used based on the American or the European guidelines do recommend semi-annual screening ultrasound, more or less AFP, depending on the guidelines. For example, the ASLD have the AFP as optional in patients with cirrhosis to detect HCC at an early curable stage. And overall guidelines worldwide, including the American, European, Japanese, and Asian Pacific, do recommend screening in all causes of cirrhosis and also in patients non-cirrhotic with HBV disease. Ultrasound which is the mostly used modality, has unfortunately low sensitivity for detection of HCC at an early stage, with sensitivity as low as 47%, as shown in a recent meta-analysis. The Korean study looking at HCC screening showed sensitivity of only 28% compared to MRI. And we know that the sensitivity of ultrasound drops in patients with overweight and patients with advanced cirrhosis, and does improve with lesion size. There's also the issue of variable quality and operator performance. So this is how you can create an abbreviated MRI protocol. There are different ways of doing it. You can do what we call a reconstructed or a virtual, if you will, abbreviated MRI, where you can take a whole exam and cut it into pieces, and you can assess the value of each component separately. So this on top shows the full MRI protocol using ganoxetate contrast, and which takes about 40 minutes more or less, and you can disaggregate these into a non-contrast abbreviated MRI. We can combine T2 and diffusion, sometimes with T1. HBP abbreviated MRI, where you can look at axial T2, axial T1 hepatobiliary phase with or without diffusion, and dynamic abbreviated MRI, where you have T1 pre and post contrast with an axial T2. All of these should be less equal 10-15 minutes in time. And these can be acquired either retrospectively from a full study or prospectively. So we have been performing HBP abbreviated MRI in Mount Sinai for the last few years. Here we inject the contrast outside the room. There's no dynamic imaging, and we combine T2 DWI and T1 at the hepatobiliary phase. And the whole thing takes about, including the setup, less than 15 minutes. Let's review the literature on the current status of reconstructed HBP abbreviated MRI studies. This, like I said, is a protocol extracted from a full ganoxetate MRI. And overall, when you look at the table, which compiles about 3 studies, it shows very high sensitivity and specificity for detection of HCC. However, there's no comparison with ultrasound. These studies also showed there was a high reader inter-observer concordance with a kappa over 0.7. In terms of dynamic abbreviated MRI or non-contrast abbreviated MRI studies, some studies are shown in this slide. In terms of dynamic MRI, these were all reconstructed and showed very good sensitivity and specificity in one study, and a Korean study, which is basically part of the prospective study comparing MRI with ultrasound, showed that the performance of the non-contrast abbreviated MRI was very good. As you can see, sensitivity approaching 80% and very high specificity. We have looked at Mount Sinai at the performance of these abbreviated MRI protocols for HCC screening. We compared reconstructed non-contrast abbreviated MRI, dynamic abbreviated MRI, and hepatobiliary phase abbreviated MRI using gadoxetate in about 230 patients referred for HCC screening. Prevalence was about 5.5%, and you can see that the performance of non-contrast abbreviated MRI as opposed to the Korean study was very disappointing, about 61% sensitivity. The performance of hepatobiliary phase and dynamic MRI were equivalent, although slightly higher for dynamic MRI, and the specificity were also equivalent, with a slight increase of specificity for dynamic abbreviated MRI. Overall, this table tells us that contrast is likely needed for the use of abbreviated MRI for HCC screening. Just one of example from this series, you can see a negative ultrasound. This patient with HCV cirrhosis undergoing HCC screening, and the abbreviated MRI demonstrated a lesion in the back of the liver that was quite small due to minimally hyperintense diffusion restriction, hypointensity on a delayed phase. This was confirmed to be an HCCL multiphasic CT. This was a missed HCC on both ultrasound and abbreviated MRI. The ultrasound was negative. Patient underwent a dynamic MRI a few days after the index study and showed this lesion next to the left portal vein that was possibly seen in retrospect on the left in the left hepatic lobe. So let's now discuss other applications of abbreviated MRI. For liver metastases assessment, there's very limited data. For example, there's a recent paper from the MGH shows that the detection of colorectal cancer mets using reconstructed HBP MRI showed excellent inter-reader agreement and sensitivity over 90%, with estimated acquisition time of less equal 15 minutes. Another study showed no difference between reconstructed non-contrast MRI with or without CT combined and a full MRI with contrast. So at the bottom is shown an example of a small lesion detected on an reconstructed abbreviated MRI. So, of course, more data is needed here for liver mets, but there's possible scenarios, for example, at initial screening and also for follow-up post-treatment. For diffuse liver disease, also there's clinical interest in this in looking at liver fibrosis, liver fat, and iron. You don't necessarily need IV contrast unless you want to look for HCC screening. Typically, this is a combination of a fat, iron sensitive sequence and MR elastography, which should be less than 15-20 minutes. And this is an example of a patient who underwent this kind of study where you can see steatosis, no iron deposition, and normal liver stiffness. Another example here of a combination of PDFF, R2-star, T2-star map, and elastogram. So there are a few limitations I want to discuss. Of course, false positives are an issue which can lead to additional exams, eventually biopsies. It's been shown in about 27% of patients may have physical harms, mostly single repeat recall CT or MRI. There's also the issue of clinician, patient, and insurance acceptance, which is really key for the more widespread use of these techniques. Future directions will be the prospective use of these techniques. So there's a prospective study looking at diagnostic performance of HBP abbreviated MRI compared to dynamic abbreviated MRI, compared to ultrasound in 4 centers, including Mount Sinai, University of Wisconsin, Duke University, and UC San Diego. And we also need more data for liver metastases and diffuse liver disease. This is the clinicaltrials.gov reference to that multi-center study. So to summarize, abbreviated MRI may represent a viable alternative to full MRI or ultrasound for HCC screening and surveillance. An optimal protocol needs to be defined, whether it's using a liver-specific agent or dynamic abbreviated MRI. And there's also a pending trial in HCC screening using abbreviated MRI versus ultrasound in the US. Thank you for listening.
Dr. Taouli, thank you very much. Very much enjoyed the lecture. You brought up a trending subject in MRI imaging today, the abbreviated protocol. And a little bit later, I'd like to ask you more about that and what you think the future is. Thank you very much. Great lecture. I'd like to move on to our next presentation. Dr. Leonardo Bittencourt will be giving the next presentation. Leo, hello. Dr. Leo Kayat Bittencourt is Associate Professor of Radiology at Case Western Reserve University School of Medicine, and he is Vice Chair of Innovation at the Cleveland University Hospital System. He served as the Associate Professor and Vice Chair in the Department of Radiology at Universidade Federal Fluminense in Brazil. And he served as the Director of Abdominal Imaging for the Rio de Janeiro at DASA Company. He served as the President of the Radiology Society of Rio de Janeiro, and he's the former Vice President of the Brazilian College of Radiology. He is a globally recognized expert in MR imaging of urologic disease. He has published more than 45 peer-reviewed papers, over 100 conference abstracts, more than 100 invited oral presentations. He has particular interest in MRI investigation of prostate and pancreatic cancer, as well as diffuse liver disease. And he is an expert in multiparametric imaging, artificial intelligence, as well as prostate cancer classification systems and its impact on patient outcomes. And in that role, he sits on the ACR PIRAD steering committee. Today, he will be speaking to us on prostate MR imaging in clinical diagnostic pathways. Dr. Bittencourt, thank you. Look forward to your presentation.
Hello, I'm Leo Kayat, radiologist from University Hospitals and Case Western Reserve University from Cleveland, Ohio. And we're going to discuss the role of prostate MRI in diagnostic pathways of prostate cancer in light of a recent publication in European Radiology. And thank you, Olea, for the invitation to this webinar. So the question has always been, should I perform an MRI before every biopsy? So is MRI to be included as an active and frequent modality in the diagnostic pathway of prostate cancer? And we have debated with this question along the time, but then after multiple prospective studies using MRI-directed biopsy pathways, now we know that the answer is a resounding yes. And MRI is now a part of all the guidelines of the most well-renowned societies and associations of urology, including the AUA, including the AAU, including the NICE guidelines, and so on, in the sense that using MRI results in fewer biopsies, so more patients are going to avoid biopsies, and the ones that are to perform a biopsy, they're going to get more significant prostate cancers detected, fewer insignificant prostate cancers detected, with the need of fewer cores overall. And this table summarizes the result of the PROMISE Precision MRI First 4M and STH-ML3 trials with large numbers of patients, and all of them showing the benefits of biopsy avoidance by use of the MRI-directed pathway, all of them showing a relative sensitivity or risk ratio for clinically significant prostate cancer increased by the use of the MRI-directed biopsy, and all of them except for the PROMISE trial showing a reduction in the detection of insignificant cancer. And PIRATES as a scoring system has also been very successful in characterizing suspicious lesions, in the sense that those are our own results from our prior biopsy cohort, showing that as PIRATES scores increase, also increase the positivity of the biopsies of those lesions and the prevalence of higher grade prostate cancer among these patients. And this has been benchmarked by other studies, including a meta-analysis not included here, but showing that as PIRATES increases the score, so does increase the cancer detection rate or the likelihood that the patient harbors clinically significant cancer. However, another publication, a multi-center publication in radiology by the Society of Abdominal Radiology, and we were a part of that as a group from my prior experience in Brazil. It received some criticism because if you look at this graph, now you see that there is a very wide variability of site-specific positive predictive values. And the criticism was that it could lead to mistrust of MRI and of PIRATES, since that different sites, they got different rates of positive predictive values by using the same parameters. But actually, according to the study design, and that was a very good response that was given after the literature, was that the variability of different factors, including biopsy strategies, experience of the readers, imaging protocols, field strengths, and so on, it was probably much more responsible for the variability of those positive predictive values than PIRATES itself or than MRI itself as a modality. So if we go back and if we understand what are the paradigms, the current paradigms for screening and detection of prostate cancer, it means that we want to detect clinically significant prostate cancer according to the most accepted definitions. This is one of them, a generally accepted definition that any Gleason higher than 7 or ISUP equal or higher than 2, or high volume or with the evidence of extraprostatic extension. And we want to not detect insignificant tumors. Again, this is one of the accepted definitions. There are more in the literature. We want to be able to adequately estimate extension and aggressiveness, and we want to allow for risk stratification and treatment planning. So the PIRATES committee was among the first to try and propose pathways for the inclusion of MRI in the diagnostic chain of prostate cancer, and how to rationalize the results of MRI and include them with the other factors that come into play for biopsy decisions and for interpretation of results. And then this seminal work from Dr. Schultz in European Urology Oncology, they organized the different combinations and sequencing of modalities and the combination of MRI and biopsy strategies to try and optimize the detection of clinically significant cancer according to different strategies and rationale. So they defined the detection-focused diagnostic pathway, the triage-focused diagnostic pathway, the MRI-focused diagnostic pathway, the balanced diagnostic pathway, and the so-called risk-stratified diagnostic pathway. The difference of the risk-stratified diagnostic pathway to the other ones was that it included additional layers of non-imaging risk stratification, so including PSA levels, PSA density, family history, information from prior biopsies, and other risk classifiers to further stratify the patients after an MRI negative or an MRI indeterminate results, and then to distribute them according to biopsy strategies. And this work was based on a retrospective assessment of the data available from the Cochrane reviews, and the literature and and Pirates, the committee, and the community that studies prostate MRI, we started to think about how to test and how to implement those pathways. Different publications came on, and our group decided also to publish about it. So we did a retrospective study on our biopsy cohort from our time in our previous experience in Brazil, including 499 patients. And all of those patients, they had an MRI that was done prior to the biopsy. All of them, they were biopsy naive. And all of them had an MRI showing at least one lesion, or if the MRI was read as a Pirates 2, and a representative area of Pirates 2 changes was chosen also. So every patient got a systematic and a target biopsy to the representative finding. So this was the ground truth of the study, and the so-called detection focus pathway represented that. Every patient got a biopsy, and what we did is that we had all the information available from the two different data sets, and we had the MRI information available. So we were able to model retrospectively what would have happened to those patients should we have applied those different proposed pathways, with a special interest in the risk-based pathway, which I'm going to explain a little bit more of detail. So every man suspected with a PSA, they would get an MRI. And if the results of the MRI were a Pirates 1 or 2 score, so a negative MRI, they would be further substratified into low risk or intermediate to high risk patients. And intermediate to high risk patients were considered those that had a PSA density equal to or higher than 0.15, a positive DRE or digital rectal examination, positive family history, or in the patients, and that's not part of the study, but in the patients that had a biopsy, patients that had an ASAP, or they were under active surveillance. And those patients that got a negative MRI, they would still get a biopsy, but in this case, because it was a Pirates 1 or 2, they would get a systematic biopsy. So we would ignore any targeted information from those patients when we were modeling for this pathway here. On the other hand, the patients that had a positive MRI, 3 to 5, the patients with a Pirates 3, they were also stratified according to the risks classification, but in case they were intermediate or high risk, they would get a targeted and systematic biopsy because Pirates 3 already represented a target. And every patient that got a Pirates 4 or 5, they would do a systematic and a targeted biopsy according to the Pirates findings. So we compared the results in terms of detection of significant cancer, in terms of detection of insignificant cancer, and in terms of the potential of biopsy avoidance across all of those studied and evaluated pathways. And this table, it summarizes the results. So the detection focus pathway, which was the reference standard, it detected, so that represented what we actually found in the population. We detected 53% of clinically significant cancer and 23% of clinically insignificant cancer in the population with zero biopsy avoidance because all of them, they did a biopsy. Systematic biopsy showed a marked reduction in the cancer detection rate of clinically significant cancer and an increase in the relative overdetection of insignificant cancer. So bad results with zero biopsy avoidance. And then the different strategies that used MRI, they were all improved in comparison to the one that did not use MRI information, but the one that was able to maximize the benefits was the risk-based pathway. Significant cancer from 23 to 18.6, that 19.2%. Few of the insignificant cancer, only 1.2% of insignificant cancer overall. It was a little bit below the MRI focus pathway, but the other factors, they came into play. And this infographic helps give visibility, not just to the readers, but also if we need to show the patients some of the benefits, and patients not often understand the importance of avoiding a biopsy or avoiding an overdiagnosis. And I think that giving this visibility improves the communication. So the detection focus pathway, it shows in green the patients that did a biopsy, but a biopsy was negative. In yellow, the patients that where an insignificant cancer was found, and in red, the patients where a significant cancer was found. And then compared to all those, we have now in blue the patients that had biopsy avoidance. So there were 12 patients, little patients with a biopsy avoidance in those two pathways and 19 in this pathway here, and including 4 little patients that they avoided a biopsy, and by avoiding a biopsy, they did not detect insignificant cancer. So we avoided not only a biopsy, but we avoided overdiagnosis here at the expense of roughly 1% of missed clinically significant cancer. So the question is, okay, we are demonstrating the benefits of introducing MRI in a risk-based pathway or whatever pathway that uses MRI for decision-making, but how do we compare the performance of one versus the other? Because like we said, the MRI focus pathway detected more clinically significant cancer, slightly more than the risk-based pathway. But on the other hand, this one avoided more biopsies, reduced further overdiagnosis. So there are tools that are being proposed to compare those complex pathways with one another. And one of the tools that is being the most used is the decision curve. So this is called decision curve analysis. It's it's in everything different than the AUC curve that we are more used to seeing. Basically, the decision curve analysis compares multiple different strategies, each one represented by a curve, and this flat line here being the biopsy known. So if we don't do any biopsy in any patient, this is the benefit that is represented by that. And if we do a biopsy in every patient, which was the reference standard, it would be the gray curve here. And how do we read this tool is that to the left of the x-axis represent the lowest threshold probability, meaning that the decisions where the patient or the provider are the most cancer averse, meaning when I cannot stand the possibility of losing a single cancer of whatever reason, and I would be willing to take the risk of any biopsy for that. So that would mean cancer averse. We would look at the curve that is at the top of that level. And then if we go towards the right, you will get more to the biopsy averse pole, which means that patients or providers that start to think that in that scenario, in that decision-making region, the biopsy represents a higher risk than to lose or to miss a small cancer. So approximately across the whole spectrum of decision-making here, by applying this tool of decision curve analysis, it was found that the risk-based pathway was the one that surpassed the other strategies available and was the one potentially more suitable for decision-making. This result, so this paper was published in European Radiology, as we said, and it got an editorial by Dr. Padani and colleagues in the same issue discussing different strategies and different proposals for decision-making in risk-based pathways. And they drew a similar scheme to the one proposed in the paper, but they included a threshold for biopsy that modulated the risk assessment in that layer between MRI and the decision to undergo a biopsy, implying that there are different factors that need to be considered, and that further studies with prospective data, with different designs, by incorporating different risk factors, they are still needed for us to come up with a unified approach for this risk-based pathway. So with that, I again appreciate the invitation and thank the friends from Olea for the invitation to join this webinar, and I'll be open for questions.
Dr. Kayat Bittencourt, thank you. I very much enjoyed that lecture. I particularly liked the decision curve analysis. I think that's a very novel way of looking at patient management, and I'd like to ask you a little bit more about that later at the roundtable. Moving on to the next lecture. This is a personal friend, Dr. Kambiz Nael. Dr. Kambiz Nael is a professor of radiology at the David Geffen School of Medicine at the University of California, Los Angeles. He is an active practicing neuroradiologist, a prolific clinical researcher, and has authored more than 105 peer-reviewed articles. His main focus of investigation includes both cerebrovascular disease and oncologic disease, particularly multiparametric imaging, machine learning, and innovative MRI acquisition protocols. On a personal note, I particularly enjoyed his papers on rapid MR acquisition for acute stroke evaluation. He is a senior member of numerous neurologic imaging societies, as well as the American Heart Association Stroke Council. Today, he will be speaking to us on the future of brain MRI imaging. Dr. Nael.
Hello, my name is Kambiz Nael. I'm a professor of radiology at UCLA, and over the next 15 minutes, I will discuss what I think the future of brain MRI may be and what direction we are headed. So, as you may know, first in vivo human MRI was performed in 1977 by Dalmatian. And then a year later, the first MRI of human brain was performed. And since then, brain MRI has been a significant part of what we do as imagers. And there has been a progressive increase in the number of brain MRI over the years. This data from 2016-2017 showed that in the United States alone, we performed over 40 million MRI scans. And brain MRI in general is a big part of what we do as imaging institutions. For example, at UCLA, about 25 to 30% of our entire volume is brain MRI. And in a very large national imaging institutions such as RadNet, when I asked them, about 15 to 20% of their MRI scan are brain MRI. Based on American College of Radiology practice guidelines, a brain MRI should cover the entire brain, should have two planes, and the commonly accepted imaging sequences are T1 and T2 flare, and gradient and diffusion imaging. So over the years, we have made significant advances in terms of improving the image quality and efficiency of brain MRI in general. Introduction of higher magnetic fields, higher performance grading systems, RF coils, improvement in techniques, including pulse sequence design, introduction of parallel imaging, denoising techniques, fingerprinting, and improvement in hardware besides magnets, such as introduction of phase array coils and improvement in digital computation for image reconstruction and post-processing. And yes, of course, there's also AI, which we'll discuss over the next few minutes. But all of these improvements have resulted in incredible efficiency of brain MRI in terms of speed and resolution and image quality that we can obtain. Currently, a routine brain MRI can be done easily in about 5 minutes. And using our scanners right now, if you are to use the sequence parameters that we will use in the 1990s, this will take about 24 minutes. So that has been significantly improved in terms of speed. You can use your advances to make a specific protocol efficient. For example, a 6-minute stroke workup can be done by MRI, and everything you really need to know about these specific stroke patients in terms of treatment decision making can be obtained in about 6 minutes, which is comparative with what you can do with CT. And again, this is really due to significant improvement in our hardware and software and sequence design. Brain MRA can be done in as fast as 6 seconds, and that is remarkable. The whole head can be imaged. That is in comparison to 6 minutes for what you can do with time-of-flight MRA. And also note that the better image quality and delineation of the aneurysm morphology using a disco MRA, for example, in 6 seconds compared to 6 minute time-of-flight MRA. 4D flow imaging, although investigational, can be now done very efficiently in as fast as 5 minutes. Again, due to improvement in pulse sequence design using variable density KT undersampling and also variable density averaging. Even if you use parallel imaging with a factor of 3, this dataset would take about 21 minutes to obtain. So again, just improve in technology have resulted in improving efficiency of what we can do. Last but not least is again, higher magnetic field, better pulse sequence design can really we can obtain very sharp, high resolution images in which we can identify small structures such as subthalamic nuclei, which are the target of deep brain stimulators in patients with movement disorders. And again, we used to basically guess where these are, and now thanks to all these advances we have made, we can actually see them, and we can target them accurately, and basically make the treatment more efficient in this group of patients. So, in summary, what we said so far is that we've made MRI significantly better. So it is more efficient, it's more accurate, and we have really excellent image quality right now. So what can we do next, let's say over the next 10 years? I think we are going to improve the access of MRI in general and brain MRI, since brain always leads the way. We are also going to obtain significantly more functional and biological data to performing brain MRI scans, and we will incorporate brain MR images and the data from them into big data in terms of basically using big data to improve basically diagnostic, prognostic, and treatment options for our patients. And I think that would be possible at least partly due to escalation and introduction of AI. I asked Dr. Wintermark, who is the chair of MD Anderson right now, what he thinks about the future of brain MRI, and he said upstream AI will modify the future of brain MRI. It allows to acquire MR images faster with a higher resolution using less or no contrast and with more clinically relevant information. So MRI access has been dismal. In 2008, only 10% of world population have access to MRI. This was improved to 30% in 2014. Still not great. And in Asia or sub-Saharan Africa, where we have about 4 billion people, the access of MRI is still 1 in a million. So we can do better. One of the ways to do this is by introduction of ultra low field MRI scans within their small footprint, with the capability of using AC just power outlet and an incredible low cost of less than $20,000, has potential really to improve the access to MRI. And these are images that are obtained from this paper in Nature Communication, where using ultrafield MRI, they were able to obtain T1, T2 flare diffusion imaging in about 30 minutes. But it looks like we're basically, taking steps back in terms of, image quality, resolution, SNR, and also timing. But again, remember, we're using incredible low magnetic field. And if we combine ultra low field MRI with AI, there is a hope that we can actually improve the efficiency. So again, these are very recent. These are publications from just last year, and we are on our way to make this happen, but it's not there. It's not available. Deep learning techniques to denoise images, they have significant potential in this paper, and they show that this specific deep learning technique were able to increase the SNR by a factor of 5 times compared to best possible denoising technique that we have, which is inverse fast Fourier transform. Again, I really think that this combination of ultra low field MRI and AI for improving image quality and SNR will change the way and will increase the access to brain MRI. The second thing that we can do over the next 10 years is to obtain more functional and biological data. I asked Dr. Andrei Holodny, who's the chief of neuroradiology at Memorial Sloan Kettering in New York, of what he thinks about the future of MRI, and he said in 10 years a functional study will be part of a routine brain MRI, probably resting state. Huge steps are being made in use of resting state functional MRI in ADHD, autism, various kinds of depression, and Alzheimer's disease. And if you look at the current issues we have with brain MRI, specifically functional MRI, signal variability, replication of data, noise, and motion are still huge problems, lack of standardized data analysis, and need for image post-processing. And again, all of these can be addressed to some extent by AI. There are software companies and startup companies specifically focusing on improving functional MRI by use of deep learning in terms of reducing noise and motion to improve image quality, and also in terms of providing automated image post-processing, so the images can be available for neuroradiologists at the same time as they're obtained. And again, that is what it takes to make this basically a routine part of your MR imaging. Other steps in terms of functional and biological data includes increase in hybrid imaging, for example PET-MR, and their role in terms of managing patients with neurodegenerative disorders. One example is Alzheimer's disease, for which there is now an approved treatment, and you can imagine that amyloid PET and perhaps combined PET-MR in this population will significantly increase over the years. Other functional imaging include access imaging in patients with neuro-oncology, and in general a multi-parametric approach. So for example, for patients with treated glioblastoma, for example, to differentiate recurrence from treatment change, a multi-parametric approach using CEST, perfusion, diffusion imaging, ASL, MR spectroscopy. All of the data we can get can be used to basically improve the accuracy of diagnostics and perhaps exclude the need for performing other imaging such as PET. And lastly, big data will be another direction that we can take. MRI, as you know, is extremely flexible to drive almost infinite contrast, and deep learning technique can extract hidden information we currently miss due to our limited visual system. And I asked Dr. Zoharczyk, who is a neuroradiologist at Stanford, what he thinks about a future of MRI, and he said we will be able to combine MR imaging, demographic and genetic information to predict outcomes, define new diagnostic biomarkers and treatment strategies, to open up a door for truly personalized medicine. So in summary, we know brain MRI is in really good shape right now. It's incredibly efficient, accurate, and we, with introduction and incorporation of AI, we can basically improve access to brain MRI. We can improve and increase functional and biological data that we obtain during our MR imaging, and we incorporate that information into big data to improve diagnostics, prognostics, and therapeutics. I finish with a quote from Bill Gates, who said, "We always overestimate the change that will occur in the next 2 years and underestimate the change that will occur in the next 10. Don't let yourself be lured into inaction." And I really think, right now, where we are with brain MRI and with, rapid escalation of AI, we can make significant improvement in the way we perform brain MRI, and those three things, improving access, getting more functional and biological data, and big data are, I think, directions that we could be headed in the next 10 years. And with that, I thank you very much for your attention.
Kambiz, thank you very much. I enjoyed the discussion of ultra-low field MR and access in around the world globally of MRI. In our first part of this webinar, we had a presentation on ultra-low field MRI and its performance. So I think I might ask you a little bit more about that in neurologic imaging in the roundtable. Thank you. That was a great lecture. I really enjoyed it. Moving on to our final presentation, Dr. Herbert Kressel. Dr. Kressel, if you could turn on your video. Introducing Dr. Kressel is in itself a humbling task. Dr. Herbert Kressel is the Miriam Stoneham Professor of Radiology at Harvard Medical School in Boston. He served as the radiologist in chief of the Department of Radiology at Beth Israel Deaconess Medical Center, where he served as the president and CEO. He was the editor of Radiology for nearly a decade, an achievement that very few people on this planet can put on their CV. He served as the science editor for the Radiological Society of North America, and he sat on the editorial board of the Journal of Magnetic Resonance in Medicine. He has authored more than 200 peer-reviewed articles. He has written numerous book chapters and is widely recognized for his contribution to the early development of clinical MRI in medicine. If I remember correctly, he was involved with the creation of the first 1.5 Tesla MRI unit that was created by General Electric in the early 1980s. And that was installed at my alma mater, the Hospital of the University of Pennsylvania. I was a medical student and he was practicing there. He is the recipient of numerous national and international awards, including the RSNA Gold Medal Award. It is a pleasure and an honor to have him here speaking with us today. Dr. Kressel will be speaking to us on international reporting guidelines. Thanks, Dr. Kressel.
Manuscripts. So I hope this highlights to you the importance. Thank you. It's my pleasure to participate in the Olea seminar and to speak to you on international reporting guidelines. The experience that we have had with the pandemic and the decline in confidence among the public in our reporting of scientific advance makes this issue of improving the reproducibility and quality of reporting of increasing importance. I'd like to begin the talk sharing with you this slide that I found in the New York Post, an article that medical studies are almost always bogus. This is from 2017. And the article went on to say, how many times have you encountered a study on, say, weight loss that trumpeted one fad only to see another study discrediting it a week later? That's because many medical studies are junk. It's an open secret in the research community, and it even has a name, the reproducibility crisis. Well, for those of you who don't know, the New York Post is a tabloid paper, sort of like the the male in the UK. But it's widely read, and it's an expression of concerns that would be widely held. Now, this notion of a problem in reproducibility, as was noted in the New York Post headline, the concern is not just limited to tabloid publications. In fact, here's an article from Nature in which they identified that somewhere close to 90% would admit that there is a concern about the reproducibility, and 52% thought it was a significant crisis. In fact, in that article, they note that 70% of those surveyed had been unable to reproduce findings reported by another researcher during the course of their career. And in industry, there have been findings again of the impact of the inability to reproduce reported results. Amgen, working with the original authors to reproduce results, replicated only 6 of 53 key studies they assessed, and Bayer Health was only able to reproduce results in a quarter of 63 studies where they attempted this. You can see the impact of this both on the scientific community and on commerce and industry. Concerns about the reproducibility of reported findings were highlighted around 2005 by John Ioannidis from Stanford. And I'm going to go into some papers that he published because I think they have some very important findings and implications. And in his paper, he noted that simulations, and this is done by modeling, show that for most study designs and settings, it's more likely for a research claim to be false than true. That's sort of a startling finding. And he goes on to note that commercially available data mining packages are actually proud of their ability to yield statistically significant results through data dredgings. And in his models, he shows the following. The smaller the studies conducted in a scientific field or area, the less likely the research findings are to be true. The smaller the effect sizes in a scientific field, the less likely the research findings are to be true. And the greater the number and the lesser the selection of tested relationships in a scientific field, the less likely the research findings are to be true. Moreover, the greater the flexibility in designs, definitions, outcomes, and analytical modes in a scientific field, the less likely the research findings are to be true. Not surprisingly, the greater the financial and other interests and prejudices in a scientific field, the less likely the research findings are to be true. And finally, and this is relevant both to artificial intelligence papers and newly developing MRI techniques, the hotter the scientific field with more scientific teams involved, the less likely the research findings are to be true. And in his study, he goes on to show the effect of these models, and he looks at studies of different statistical powers, well-powered to poorly powered studies, the pretest probability, sort of what's known about the question, and how likely is it that you can narrow the true effect, the degree of bias in the study, and then different types of studies, and finally, what would be the positive predictive value of a result. And sort of the best results, not surprisingly, were in a well-powered, confirmatory, meta-analysis consisting of good quality randomized controlled trials with a modicum of bias. And there, the positive predictive value was 0.85. If you look at a lesser powered meta-analysis of small inclusive studies with a lower pretest probability, that's not well traversed scientific question, and a higher degree of bias, you see that the meta-analysis of small inclusive studies, the positive predictive values decreases to 0.41. If you go and look at single studies, a lower powered, underpowered, but well-performed phase 1 or 2 randomized controlled trials, where it's a phase 1 or 2, so the pretest probability is lower. There's not a lot of bias present, but nevertheless, underpowered but well-performed phase 1 and 2 randomized controlled studies, the positive predictive value drops to 0.17. And if we go into the discovery-oriented exploratory studies, which is what we see for a lot of the new technologies in imaging, they tend to be underpowered. The pretest probability is low because they are exploratory, and in the way these are commonly conducted, there's a potential for a high degree of bias. And you can see that the positive predictive value drops to 0.001. So it's not surprising then that the results obtained in a study like this might be very difficult to reproduce. So guidelines actually improve the quality of the reporting. And the way they do this is they help us identify the presence and nature of bias, help identify methodological problems, for example, sample size issues or inappropriate analysis, help ensure that the description of the methods is adequate to reproduce the study. But most importantly, they don't ensure that a study is novel or important or interesting. So a study that is well done and that has results that may be reproduced may not be worthy of publication for other reasons. So they talk about the mechanics of the study, but they don't ensure the novelty or importance of a study that is reported. This is one of the most important slides that I'll be showing you today. This is the website of the Equator Network, www.equator.network.org. And this is a site that aggregates internationally approved guidelines for different types of studies. And this is sort of the landing page, and you can see links to randomized trials, observational trials, systematic reviews, case reports, diagnostic or prognostic studies, quality improvement studies, economic evaluations, and the like. So this is the landing page, and then you can move on, identify the type of study, and get the details of what should be included. And they all have an explanatory document that will describe to you why this is important to include in reporting. And the ones that were most important to us in the journal Radiology, when I edited, were the STARD standards for reporting diagnostic accuracy studies or diagnostic performance, the CONSORT standards for reporting randomized control trials, consolidated standards of reporting trials, and then the PRISMA, the preferred reporting items for systematic reviews and meta-analyses. So I would encourage all of you to look at these before you begin to plan your research, and certainly before you begin to write it. Now, a hot area for us to consider is artificial intelligence issues. And Lord knows there have been considerable problems in reproducibility with these studies. And some of the concerning areas are that the training data that's used will influence the performance. And so variability in it and problems with it is very important. A number of the machine learning type AI efforts use feature tagging. And there, the expertise of those doing the tagging is very important. Is it a medical student? Is it an experienced imager? What is the expertise is very important in the results and also in the reproducibility. Techniques can vary of the studies that are included in developing the AI technique. And so the effect of technique variation on performance is important. And then the issue of the need for a split sample validation, where for the internal training of the tool, commonly the initial training sample is split. And so problems with it are then carried over into the second sample that is used for internal validation, and that may be a problem. Very, very important is the need for external validation beyond the training set, and this really should be multi-center. And that is has been a problem with a number of the submissions we've seen in radiology. Spectrum bias is another concern. When you're trying to use AI for a given application, are you including images and patient data on the full spectrum of the presentation of the disease that you expect the application to be helpful in? And finally, not surprisingly, this notion of data dredging and overfitting multi-parametric data is commonly done and leads to lots of problems. A checklist for artificial intelligence in medical imaging was developed by John Mongan, Linda Moy, and Charles Kahn for radiology artificial intelligence and radiology in general. And it's very, very helpful and have been widely used. It's not yet been approved by the international guideline website that I shared with you, but it's helpful. And I do understand that the START group that is working on an extension for artificial intelligence manuscripts. So I hope this highlights to you the importance of high-quality research design, the use of internationally approved guidelines to help structure the research, and most importantly, the need for care in doing this work. I thank you very much for your attention.
Dr. Kressel, thank you. That was an excellent lecture. I'm sure we're going to bring in a lot of discussion on that. Thank you very much. Can I ask all the panelists to turn on your videos? I'd like to ask some questions, and I'd like to encourage cross answers between our panelists if you have an opinion. Also, because people know that I am moderating, I am receiving questions on every possible medium, including my cell phone. So please excuse me if I seem a little distracted reading from multiple places. Dr. Taouli, I'd like to begin with you. Because I find that abbreviated MRI is a truly emerging idea in radiology today, and it's something that touches on the practice of all of the radiologists who are here right now. You highlight that abbreviated MRI disease and task specific and triage oriented, is an emerging and easier and perhaps better technique for us to be used. In essence, you emphasize that less is more, less sequence, no contrast, or if you use contrast, dynamic contrast only, using liver-specific agents like gatoexetate. But I know that there are radiologists in practice who believe that more is more. Basically, they're fearful of missing a diagnosis with an abbreviated protocol. And I've heard this conversation in breast imaging as well. There's a debate about standard versus abbreviated protocols. So what do you say to the radiologist who's worried about missing that finding, who's worried about not making the diagnosis? Because for many of them, when they do their MRI, they get their reimbursement for it, and that's the patient's one shot at getting an MRI. Can you speak about that? Allay the fears of using this abbreviated MRI to answer a very specific question.
I think there are two. I read two questions in your question. So one of them pertains to just the standard, MRI and the way we're building it, and it is so easy to add sequences to a protocol because we think it's of course radiation free, et cetera, and you can just pile up this number of sequences, and you realize actually that you may be examining maybe 40% of the images at the end, or maybe 50%, because there's so many sequences that are there for either trying or maybe adding something, et cetera. So I think make sure that your protocols are lean is so important these days with the decreased reimbursement, the competition for spots. I mean, our MRI time, to get an MRI at Mount Sinai, it's about 2 to 3 week delay. And it's so important that we look at that, come back to a more lean way of examining our patients. So that's number one. But now for abbreviated MRI, which is kind of, overlapping with the first topic, I think the indication has to be clearly precise to decrease the fears. You cannot just say, let's just do abbreviated MRI on everybody. That's not going to fly. But if you really target it to certain questions, that's going to be the solution, of course, with a lot of other conditions, including validation, acceptance, et cetera.
So I'm going to ask the other panelists to join in, but there's a second part of that as well, and that is you also mentioned this increasing global incidence of hepatocellular carcinoma and mixed tumors, and the need for increased surveillance, increased triage. So has the time come, given the low sensitivity of ultrasound, has the time come for MR to replace ultrasound for that kind of a triage? And I ask the same question to Dr. Pinker. Has the abbreviated protocol for MR breast, has it now come to the point where it can serve as the screening exam?
I think you have to look at this question in a differentiated way. So first of all, I 100% agree your protocol should only have what is necessary and is really dependent on the indication. If for an abbreviated protocol, if the question is recall yes or no, for in a screening setting, an abbreviated protocol is definitely enough. If you have the question staging, differentiation of lesions that you already know are present, you will need a full protocol. And there also has been a recent study which looked at, is an abbreviated protocol in the high-risk screening population, is that actually enough? And it was shown that in this particular population, T2 actually is necessary to avoid an overcall of tons of false positive recalls. So that's one thing. The thing is, there is now evidence that, and we know that MRI is the most sensitive test for breast cancer detection. That is a fact. The thing is, you cannot offer or recommend something for screening which is not ubiquitously available. That's one thing. And abbreviated MRI is a way of making MRI in screening more cost effective, and you can offer it to a larger population. But before you can recommend something widespread, it has to be available. Yeah, we have DENS, we have the ACOG-Akron trial, which all show MRI makes sense. In particular, abbreviated would be an option for screening, and the DENS cost analysis shows that you could actually also make it cost effective if you do it every 2 or 4 years. But before we can recommend it, it has to be available to everybody, and that is currently just not the case. I mean, I'm a proponent of MRI, and also I think we have to look at it differentiated, who actually, we don't have it for everybody and who should get it. These are then the women who have the dense breast, where sensitivity of mammography in screening plummets in women with extremely dense breast to 30%. This would be the population I would pick the first for screening with MRI instead of offering to everybody. That has to be a differentiated approach based on indication and also on risk factors.
I just want to echo what Dr. Pinker just said. I don't think we are able in 2022 now say that MRI will replace ultrasound for liver cancer screening. That's going to be, over ambitious statement, and we don't want that actually, because ultrasound does a good job in certain patients. So I think we need to be able to stratify and kind of classify the risk. That's very important. That risk stratification, and also based likely on BMI and degree of liver disease, that's going to be really important. If you have somebody who's Asian, lean Asian, HBV non-cirrhotic, it's okay to do an ultrasound. It's going to be totally acceptable. If you have somebody who's like over BMI over 29, advanced cirrhosis, then those cases should go for an MRI screening. So there's like really an importance of getting more data out and trying to classify and risk stratify, the outcome of quality of the study and also the risk of HCC.
So this is a pretest probability type of decision that we're talking about here. We're talking about tailoring our exams on that pretest probability. But very often our medical billing doesn't come in that way. Things are ordered as MRI of the liver, and that's sometimes, or MRI of the breast. And I think that's maybe part of the problem for practitioners specifically and the field in general.
I can only speak to breast, but in breast it is a differentiated approach. For instance, if you are a verified high-risk person with a lifetime risk of greater than 20%, you should be screened with MRI. This is the official recommendation, and you will get it. There is now recommendations for consider it for greater than average risk of breast cancer, which is like with a high-risk lesion or personal history. So this has, in particular in breast, decisions for ordering exams are already based on that, are reimbursed based on that. You're like, if you have a dense breast, your insurance pays the ultrasound. In Europe, there's the formal recommendation from the European Society of Breast Imaging now that in women with extremely dense breast, an MRI should be done regardless of risk. So there's in breast, this concept is already taken off. There are also like AI models which calculate, we more accurately can assess your risk when imaging is included. So I think in breast, we are already have that integrated, at least to some extent, in how our tests are ordered and how they are reimbursed.
Okay. Dr. Nael, I know that you have experience in these abbreviated protocols and you've written about that. Are you seeing the emergence of abbreviated protocols in stroke imaging?
Yeah, Adam, as a matter of fact, I think for a stroke, I think maybe a stroke was one of the earliest adapter of this this approach, but the specific stroke protocol using MRI has been adopted. I would say maybe over the last 6-7 years. We're currently using it at UCLA. So in patient when they come to ER, if the MRI is open, they're basically taken straight to MRI, and we do this 6-minute stroke protocol that we have. And I think there are some other institutions that they're doing it. So I think that's because the specific about the stroke and the time sensitivity that is related to its treatment. I can't recall any other protocol specifically for neuroradiology, at least, that we have this type of approach. For example, we have dementia approach, we have epilepsy protocol, but none of them. The focus is not really on fine tuning the time, and it's rather to get more detailed, high resolution images as opposed to like focusing on the time. Stroke is really the only thing I can think of in neuroradiology that I think is time sensitive, and I think we've done a relatively good job over the last few years in adopting that approach.
Thanks. You, all of you, touched on artificial intelligence. Even though this is not an artificial intelligence webinar, when we spoke about the future, it permeated all of the lectures. And I'd like to speak about that first a little bit. The first thing is that Dr. Pinker and Dr. Kressel had two interesting perspectives on artificial intelligence. So we'll start with Dr. Pinker. She said that there's a long road to bring in artificial intelligence into daily practice. But when I listened to your lecture, it really touts the power of artificial intelligence, improving lesion classification, molecular subtyping, better risk assessment. When you use multiparametric imaging, you can differentiate triple negative from luminal A and gene expression. So I'm wondering, why isn't AI ready for prime time? If specific algorithms do specific things, and we have a study, and even just a few studies that show that it does that specific thing, why aren't we bringing it into daily practice?
Again, this is also again the differentiated question, because like in screening, there are commercially available solutions which are in practice. This has in screening, in particular in Europe, there are several. There are actually approvals now for using the AI as a standalone second reader in the setting where you really, in particular in countries where you really have a mandated second reader, which is, for instance, Germany. So there it is actually in daily use. The majority, often it's also used to sort the work list for the radiologist. The problem is it's not really classified. Is a computer a legal responsible entity? That is, and I have a whole presentation on that as well. The problem is, like, who do you sue in the end of the day if there is a misdiagnosis or a missed cancer? There are already very well thought through concepts who you can sue, but they differentiate from the FES in Europe. But in screening, I would say AI is already helping us. For the molecular subtyping and the other thing, these are single institution studies. These are smaller studies. Before you can actually like put that into clinical practice, you will need larger. We have heard you need external validation cohorts, you need larger scale studies. So that's why these things are more still in the research realm. That's one thing. And also, I mean, just because we radiologists think that we are ready for prime time doesn't mean the clinicians think that we are ready for prime time. When I think about how long it took us to actually get MRI of the breast established in the preoperative assessment, basically after the horrible Kambiz and Monet trials, which gave us a bad name, it took us more than a decade. So that just because we know that it is working, we now have to find ways to convince our clinical colleagues that this makes sense. But in the screening setting where we radiologists are the gatekeepers, AI is already helping us.
So, Dr. Kressel, is this an adoption problem or is this a validation problem? You spoke about the general difficulties of creating artificial intelligence algorithms, the amount of training data, the variable expertise for the labeled data sets, the type of techniques that are used, internal validation, of course. So what do you think the future of MRI looks like, and what is its adoption pattern going to be? And are we going to fall into the same trap that we've fallen into before for other new innovations?
I think it's a very good question. The important thing to remember is that diagnostic performance is not fixed. It's affected by so many different things. When we get the reports, the way the study is carried out, the reference standard that you use, the way patients are selected. So all of these things are going to affect how, quote, useful you wind up thinking any given advances. So I think in part, the way for us to adapt to this is to work in larger groups and to have more data registries, more large-scale studies that are developed, that are designed to effectively answer the questions of utility of a given advance. And I think as I look at medicine, I think the cardiologists have done a very good job with this in taking advances and having an infrastructure that is really able to evaluate them and put forward in a meaningful way the utility. And I think the other thing that we can do is not take this burden on ourselves as radiologists alone, but work with other specialties. It makes a big difference if an advance in cancer is being supported by the radiologist alone, or if it's also been approved by the NCCN. So I think there are, that is the way for us to go. I think it's tempting to jump on a bandwagon and then you can get yourself, your knees scraped when you fall off the bandwagon. And so I think to have an infrastructure that facilitates high quality evaluation of these advances is the key.
So the conversation has been great. We're actually over time. I think the conversation's been more animated than we anticipated, and the questions coming in. I have a question for you, Dr. Kressel. This is a difficult question, perhaps. You spoke about guidelines and how they're used to identify the presence and the nature of bias and methodologic problems, problems with description and communication of studies, but how these guidelines don't give you insight on the importance or the innovation of the thing being studied. But on the other hand, studies that have a very low pretest probability, and on the chart it was like 1 to 1,000, 1 to 2,000. These are discovery-oriented studies, and they have a very low positive predictive value. So if people, and by people I mean the government and funding organizations, if they start concentrating on this type of high-yield guideline, do we run the risk that potentially innovative or breakthrough studies will be ignored if people start to become risk adverse, if they start to become non-reproducibility averse?
Well, I think that's a very good question. There's definitely a role for exploratory studies. The problem is that a positive result on an exploratory study shouldn't be the gateway for generalized adoption until we have tested a bit more rigorously. So I think when we were in radiology, we published a lot of studies that were exploratory, and commonly we would define these as hypothesis generating. This is an intriguing result that could be very important, and it helps the scientific community generate a hypothesis which can then be tested in a more rigorous fashion. The problem with ignoring the need for more standardization is that it makes us a target. When things don't work out, we're viewed as just leading the parade for financial or other reasons. So I think we do ourselves a better service if we allow exploration, but then follow it with rigorous studies.
Thank you. That was a great answer. I appreciate that. We are over our allotted time right now. Unfortunately, there are many more questions coming through. We need to wrap this up at this time. I would like to thank all of our speakers for taking time out from your busy schedule. We truly appreciate your time and your effort and joining us today. I'd also like to thank all the viewers out there. I'd like to thank the people at Olea responsible for this, who did the hard work to put it together. Thank you, everyone who's watching, for your time and attention. Wish you all a good day, and take care. Thank you.
Thank you.
Thank you very much. Thank you. Bye.
Bye-bye.